Hello, my name is Dr. Mark Alberts. I'm professor of neurology and head of the stroke program at Northwestern University in Chicago. This Medscape video blog update is going to focus on the ACTIVE-A study, which was a very important study for the prevention of stroke in patients with atrial fibrillation. This was reported at the recent American College of Cardiology meeting in Orlando and published online in the New England Journal of Medicine. What ACTIVE-A did is that it took patients who were in atrial fibrillation with increased risk factors for stroke. A little bit more than 7,500 patients were randomized to receive either the combination of clopidogrel plus aspirin or aspirin alone. The dose of clopidogrel was 75 milligrams a day. The dose of aspirin was a low dose, 75 to 100 milligrams a day. This was a prospective, randomized, double-blind placebo trial, but again, all patients received either clopidogrel plus aspirin or aspirin alone. The primary endpoint was a combination of stroke, MI, or vascular death, and patients were followed a little bit longer than 4.5 years at the longest. So what was found at the end of this study? Well, what was found in this study was that the combination of clopidogrel plus aspirin compared to aspirin alone was more effective for the prevention of the primary endpoint of stroke, MI, and vascular death, with an absolute risk reduction of almost 1% per year. And if you look at the endpoint of stroke, the absolute risk reduction was a little bit more than 1% per year. So this sort of answered the question in terms of whether combination antiplatelet therapy with clopidogrel plus aspirin is more effective than aspirin alone for preventing stroke in a certain group of patients with atrial fibrillation. Now, there was a cost for using the combination antiplatelet therapy, and the cost was an increase in serious bleeding events, which were increased less than 1%, however, in the combination group versus aspirin alone. There was not a statistically significant increase in fatal bleeding using the combination therapy versus aspirin alone, although there was a trend in this direction. Interestingly, however, most of the major bleeds and fatal bleeds were GI hemorrhages, not cerebral hemorrhages. Now, what types of patients got into this study? Well, it was patients who, in the opinion of their treating physician, could not or should not take Coumadin therapy for their atrial fibrillation, or in some cases the patient did not want to take Coumadin therapy. So I think this is a good real-world example of a large study of over 7,500 patients, again randomized to clopidogrel plus aspirin versus aspirin alone, for the prevention of important vascular events with underlying atrial fibrillation. So how do we put these study results into context? Well, I think looking at all of the available literature and data, it's still clear that Coumadin is the most effective medication to prevent strokes in patients with atrial fibrillation, particularly if they have additional risk factors for stroke. If for some reason they cannot take Coumadin, then aspirin and clopidogrel is probably a better alternative than aspirin alone in terms of efficacy. Aspirin alone is probably the safest alternative in terms of the fewest bleeding events, but it also is the least effective therapy. So there you have it, ACTIVE-A really proving that combination antiplatelet therapy is better than aspirin alone for stroke prevention in certain groups of patients in atrial fibrillation who cannot or do not take Coumadin therapy. Thank you very much for joining us for this Medscape video stroke update. Have a good day.